You're listening to Nitty Gritty Nursing with Nurse M, where she breaks down the nitty gritty basics of nursing concepts. All right, welcome back to Nitty Gritty Nursing with Nurse M. I've had a topic request, and so this is going to be my stab at covering specific considerations for cardiogenic shock. Now, if you listen to the shocks episode, there's two of them. I just briefly touch on it. This is actually a shout out to Sarah Eismeyer, actually for shooting me the email and asking about this topic. So I'm going to try to take a much more in-depth look at cardiogenic shock specifically because of all the shocks that we talk about, this one is, in my opinion, one of the most complicated one. Because cardiogenic shock is where the pump is broken, the pump being the heart. When you think about the other three types of shock, so there's four total shocks, okay, cardiogenic, where the pump is broken. You've got hypovolemic, where there's just not enough fluid intravascularly circulating, and those are going to be your dehydrated individuals or the, people that are bleeding. It's too much of the red stuff outside when it should be inside that vasculature. Your distributive shocks, which is going to be like anaphylaxis, and then you've got obstructive shock, which is your pericardial effusions or straight up pericardial tamponade, where the heart is obstructed from actually being able to pump appropriately. And the distributive shock, you might also see it or read about it being called vasodilatory or shock because it's everywhere, it's distributive. So when we think about this, cardiogenic shock, every time you should have some sort of basic algorithm in your brains, especially as you're going into nursing, especially if you're going to work in a critical care environment, about how you make a determination of what you think your patient is going to need if they are in shock, and how you should actually think about and the process to anticipate of what they might need. And realistically, like at least for me, and I think for others, as you go out into the beautiful world of nursing and you start interacting with patients who might be in shock, you will start to develop these algorithms yourself. For example, the first step is always to assess and address if they have enough circulating volume at first. Mainly just because it's super easy to fix. You do that in all shocks. And in patients in cardiogenic shock specifically, they actually do have enough circulating volume cycling through. And this can often, especially like in the emergency room, if you're wondering, it can be determined by a provider at the bedside, and they can just, take a portable ultrasound, for example, and check. They literally look at the way that the heart is beating and see if patients might be fluid responsive, or if they potentially have like an elevated filling pressure. Ultimately, patients with some sort of cardiac issue or long, chronic cardiac condition, if we need to measure those pressures, they will go to the cath lab to get an accurate, inside the vessels, inside the ventricles or the atriums, those pressures. The second step, so first step, figure out if they need the fluid. In cardiogenic shock, they don't. But that's your first step. In all shocks, this is all shocks. If you're like, man, that patient looks shocky, be like, do they need the fluid? The second thing is to then address any sort of inappropriate vasodilation that's happening. When you think about that distributive shock, that's inappropriate vasodilation because those vessels just, expand. So in cardiogenic shock, again, this is not a problem. They don't have inappropriate vasodilation. They're actually already clamped down. Versus that person who's in sepsis, when you see someone who is septic for the first time, they're vasodilated, they're warm, their skin is hot to the touch, and they have no blood pressure, or they have very low blood pressure in that hypotensive state, hence why we've determined that they are in shock because those vessels have dilated. The third thing that you have to consider, okay, so first, fluids. 2, what's their vasculature doing? Is it clamped? Is it dilated? And then 3, the third thing to consider in all shocks is ultimately like, how do we increase cardiac output? Because ultimately that is the problem. And in cardiogenic shock, this is key. In cardiogenic shock, I cannot stress enough that the entire premise of the treatments that patients receive and the monitoring and the cares that we do as nurses is to improve and increase cardiac output in cardiogenic shock, because that is the problem. That is the root of the problem. So for this particular episode, when we talk about cardiogenic shock, I'm going to do the whole pie approach of your patients. But I think in order to make it a little bit more clear, we have to do just a very basic overview of what cardiogenic shock is. Because I have said that it is the failure to pump properly, which ultimately, again, results in decreased cardiac output. And if you have decreased cardiac output, that means blood's not perfusing adequately. So tissue perfusion is now compromised. And ironically enough, if your tissues are not getting the blood that they need, neither is your organs. So identifying this is the most important factor to recognize when someone is in cardiogenic shock, but identifying that they are not perfusing their organs is key. So once we identify, the entire goal of treatment and everything that we are doing with these patients is to not only increase or improve the cardiac output, but to then thereby or subsequently maintain tissue oxygenation and the perfusion to the organs. And we often, most commonly, do that with a vasoactive medication. And you're going to see those vasopressors or the inotrops or the inopressors, which an inopressor is just an inotrope vasopressor. In some cases, though, the patients are non-responsive, or it's not enough, and so we will then have to incorporate mechanical circulatory support. And I think the most common one that people talk about is the intra-aortic balloon pump. There are also devices like the Impella device that can be inserted to help sort of ease the strain of the heart and continue that cardiac output perfusion while the heart heals or while we address those issues. Now, I will do a separate episode on the differences and when we would use in nursing cares for Impella devices and intra-aortic balloon pumps, because when I was putting this particular episode together, there's just, when we talk about cardiogenic shock, there's a lot that I'm going to go over that I think is important. So stay tuned for that. It will come at some point. Again, why do your patients end up in cardiogenic shock? There's only 2 reasons why your patients will end up in cardiogenic shock. The first reason is that they have some sort of coronary problem. And we see this most often in individuals with an acute myocardial infarction, literally an acute heart attack. Because when we get that clot in the vessels that are feeding the heart, your heart is just a muscle. It never gets a chance to take a break. So when we get a large clot or an occlusion, a lesion is how you might also hear it referred to, inside the vasculature feeding the heart, that heart muscle starts to die. So if your heart muscle is not being perfused, it dies and then it doesn't work, or it doesn't work to its full extent of what your body is used to or requires for the basic functioning of living. And if it doesn't work, it loses the strength to contract appropriately. And because it cannot contract appropriately, that causes decreases in cardiac output and then the cascade of problems that follow. Think about it this way. If you go out for a jog and you're running down the street and you've just laced up your shoes, your sneakers, and you go to step off the curb and you turn and you wave to a neighbor, I don't know, I'm making this up, and you twist your ankle, right? And the muscles, theoretically, I know this is a terrible example because there's also ligaments and tendons, blah, blah, blah. Okay, but if the theoretical muscles around your ankle have been stressed or damaged or injured, it's not like you get up and you're like, no, it's okay, I'm totally fine, I'm going to keep going on my jog and run on this damaged part of my body. It doesn't work. Instead, you hobble, okay? Effectively, cardiogenic shock is your heart hobbling because the muscle is damaged or is not adequately perfusing when we talk about the coronary aspect of it. So that's the first reason. You have some sort of coronary problem. The most common one is acute myocardial infarction, damages the heart by not perfusing the actual muscle of the heart, and then the tissue starts to go through the whole inflammatory process. Okay, the second reason, ironically, if you're thinking in your head, well, if the first reason is coronary and the second one can't possibly be coronary, you would be correct. So the second reason why individuals end up in some sort of cardiogenic shock is from a non-coronary problem or something that has stressed the myocardium that is resulting in ineffective function. And in this case, think about those individuals with acute on chronic heart failure. So if you have heart failure at principal baseline, you've developed it or you've got some sort of cardiomyopathy that you've lived with for years, and then you have an acute exacerbation of that, that is not a coronary problem. It is not like a vasculature problem feeding the heart. No, your heart is just strained and to begin with. So when we think about that, if they have cardiomyopathy and they are poorly managed, or perhaps they don't have access to the resources, or, there's a socioeconomic feature to this where they can't afford their medications, and the heart failure is exacerbated, the heart doesn't pump correctly or adequately. But in this case, it's not because of a coronary problem where there's death of the actual tissue, the heart, but rather it's because the heart is failing for a different reason. Interestingly enough, when I was getting this episode together, right, there is actually a new scale. For the longest time, it's been really kind of hard to rate, or at least in my own experience, it was really hard to understand the degree or the severity of sickness with people that were identified as cardiogenic shock. Oftentimes, mainly just because working in the emergency department, the people that came in cardiogenic shock were real sick. But there's actually now a new scale to determine the degree of severity for patients who are suffering from cardiogenic shock. And this is a scale that was put out by the Society for Cardiovascular Angiography and Interventions. And then it was endorsed by the American College of Cardiology, the American Heart Association, the Society of Critical Care Medicine, and even the Society of Thoracic Surgeons. And it's a beautiful pyramid, but it's a pyramid that they have outlined to show the degree of severity and what it does for your physicians, your providers who are doing the treatments or making, really big decision care plans, is it gives them a good framework to say like, oh, if this patient has cardiogenic shock, here's what I would expect to see, and here's some interventions that I can do. Now, when you look at the pyramid, it's A, B, C, D, E. A is the very bottom layer, B, C, D, E is the very, very top layer, okay? And the best part about this is that they correlated each level, the A, B, C, D, E, with the first letter of the patients that fall into this cardiogenic shock pyramid. So A was at risk of developing cardiogenic shock. So if you have a patient that comes in having a heart attack and they go to the cath lab and we get reperfusion therapy done and everything's great, but because I still had that heart attack, there's still going to be some degree of cardiac tissue damage. So they are at risk at some point of developing cardiogenic shock. Or, if they have acute heart failure symptoms, again, they're at risk for the development of cardiogenic shock, but they are not in cardiogenic shock specifically. So those are just the at-risk people, followed by B, which is the beginning stage. And this is when you first develop cardiogenic shock. And because of that, if we think about shock, the two big things that you should automatically pull to your brain is hypotension, tachycardia. And this is when these individuals who start the beginning stages, they don't have any vasoactive medications on board to start to manage it, but because they are still warm and maybe minimally, they might have some small changes in some of their lab values. Like you might see their creatinine elevated. We know that the renals really require a lot of adequate perfusion. And in shock, if we are hypotensive, the renals, the guts, those are usually the first two big areas that have the reduction of blood flow initially. So we'll see an elevation in maybe creatinine and then lactate, right? Lactate, but it's going to be normal, okay? And they might have some evidence of low cardiac output. We're going to get to that. C stands for that classic cardiogenic shock with hypoperfusion. So they've got the hypotension and they need some sort of inotrope or vasopressor because they don't look good. And when we have that poor cardiac output, these patients come in and they even have like mottled skin and they seem fluid overloaded and confused. Well, they're confused because they're not adequately perfusing essential organs, and also in cardiogenic shock because the left ventricle or the ventricles are, they're not pumping. It's a pump problem. The pump is not doing its job and pumping and perfusing. So because of that, it's not perfusing hypotension. It's not perfusing, we're going to be confused. It's not perfusing volume overload in the sense that the blood gets stopped. It gets backed up into the lung system. And so we end up with seemingly volume overload because they're going to have really wet lung sounds. And then, they'll be oliguric because now that blood they're not perfusing. Now the renals, they're not being perfused. So they will have abnormal lab tests, etc. So they are in classic cardiogenic shock. The D stands for now deteriorating or doom. And it's very similar to the classic cardiogenic shock, but these individuals, we can start those medications. We can start the inotropes and the vasopressors and try to get the cardiac output up to a point where it needs to be, but they are failing to respond after about 30 minutes of the intervention that we have done for them to improve it. So, for example, they're in cardiogenic shock, so the provider orders a norepinephrine drip, maybe an inotrope, and they're not getting better. They're getting worse. So you start that norepi and they're not getting better. These are people that in cardiogenic shock that fall into the D or deteriorating or doom. In that D level, the deteriorating or doom level for cardiogenic shock, because of the pharmacological management that we're doing, and they're not getting better on multiple potential vasoactive medications, this is the classification where now they need some sort of mechanical device, like the intra-aortic balloon pump or an Impella device, because the medications are not working, the heart is not working, this is bad news bears, we need to cross-correct. And this is when that mechanical element will come into play. The E is actually called extremis. And that is when there is like circulatory collapse, where they're near pulseless with hypotension, or they're in and out of cardiac arrest, and they do CPR and they get ROSC. And then because they're in extremis, because the heart cannot pump, they go back into it. It's a whole thing. So the whole point of cardiogenic shock ultimately is to identify that they're in it. This brings us to, okay, that's a general overview of it. Now, how do these people present? The individuals suffering from cardiogenic shock. In simple terms, just break it down, the nitty-gritty version of it. Think about it, it's warm versus cold and wet versus dry. And if you're like, what? Okay, because in cardiogenic shock, we know that cardiac output is affected. And as a result, that means that organs are not going to be perfused. And the circulatory volume or the blood is not being pushed through the heart correctly because the heart cannot do it because it is broken. It is damaged. The pump is broken in some way, shape, or form. When the renals don't get perfused, it activates the RAS system, first of all. The whole idea behind warm or cold is people in cardiogenic shock, what you will see they are cold and wet. This is a typical classification. And what that means is the distal extremities are really cold because cardiac output is not there. If the fingers are not perfused, they are cold. They are not getting warm blood to them. And you will see, even if you have a pulse oximeter on their finger, look at the monitor. And if they are not adequately being perfused, that pleth waveform, they will have a poor pulse ox pleth waveform because there isn't good flow through that capillary bed to be picked up. So they're cold because they start to clamp down, because they're hypotensive because the heart is not pumping. They're also wet. And what does that mean? It's not like their body is wet like someone in diaphoresis. No, they have pulmonary edema. And if you sit there for just a minute and close your eyes and just envision how the blood flows through the heart, okay? Let's pretend that left ventricle is broken. It's not doing its job. So the blood comes into the heart, it goes out to the lungs, and from the lungs, it's supposed to drop into that left atrium to the left ventricle. Well, the left ventricle's not pumping anything. So the blood is just kind of hanging out in the lungs, waiting to get to the left ventricle for perfusion. Well, when we get so much blood back up into the lungs, and it has to go somewhere. It's not just going to hang out in the vessels because you have to have movement. So as it starts to leak and we end up with pulmonary edema, that pulmonary congestion. So when you're listening to these patients, they sound terrible. There's a lot of fluid in there. It's fluid sounding lung sounds. And so their extremities, their feet, their legs, their arms, their hands are cold and their lungs sound terrible. So people who are both cold and wet, you need to think and worry about cardiogenic shock from that left ventricle failing because the blood's not getting out. So it's not getting to the extremities to perfuse. You're going to be cold. There's some constriction occurring naturally, and it's backing up into the lungs. Versus, and you're like, I don't understand what this means. Okay, versus someone who might be warm and wet. Okay. Someone in like distributive shock. So let's say with sepsis, for example, right? Sepsis is that raging infection through the system, which causes these inflammatory cascades to occur, and that causes vasodilation. Well, the vasodilation, right, as a result of that infectious process and the inflammatory process leads to vasodilation with capillaries in the lungs that start leaking because of the inflammation. So in sepsis, you will also have potentially wet-sounding lungs, but their skin is warm. They're febrile, right? So cardiogenic shock, wet and cold. And someone who shows up or presents to you with cold hands, cold feet, and you think they're in shock, consider that potential for like poor left ventricle function. Even when you're doing your skin exam as a nurse, if your patients present that way and they've got those junky-sounding lungs, and you think about it because they're clamping down, it's really interesting because that clamp down process, right? They go basically from really cold skin to now fairly warm skin around the knees or the elbows at the beginning, okay? And there's usually this modeling that occurs like distal to wherever there's this temperature change. And it's not a clot. It's because they're so clamped down because their heart is not adequately pumping out. other things you'll see in the presentation of these patients. Okay, we're going to go over those. But the hallmark thing is, if in practice, they're cold and wet. So they have really cold hands, really cold arms, and then weirdly enough, like their biceps might be like normal temperature. Similar with the legs, really, really cold feet, lower legs, calves, and then usually about around the knees, or if you on the thighs when you're doing skin assessments, it's not the same temperature, and it's bilateral. It's not unilateral, so it's bilateral, and you'll see mottling. The other things that you will see, and the other way that these patients will present, are going to be with hypotension. Because of the poor cardiac output, usually their systolic blood pressure will be less than 90 millimeters per mercury. They will also be tachycardic, because as the body tries to compensate to perfuse those organs that are being affected, the heart speeds up, but it's not working. You'll also see increased respiratory rate, so they'll be tachypnic because the blood in the lungs that is supposed to be going to the body is backed up. So the organs, even the brain, they're not getting the oxygen they need to be happy. So again, a compensatory effort that will be kicked in. The lung sounds, again, will be junky because of the pulmonary congestion that is occurring. You're likely also to see that hypoxia or low O2 saturation, again, with that poor pleth, because the capillaries are clamped down, the vasculature distal is clamped down, so your O2 saturation, that pleth, that little waveform that you see on your monitor, is going to be very poor because there's not enough blood adequately circulating through for you to get a really good reading. And then also, the low oxygen or the hypoxia, it's because all the red blood cells with the lung ready for the deposit to all the cells and the tissues, they're stuck in the lungs. They can't get out because the heart is broken. It's not pumping correctly. And then eventually, what will happen is you may also see a jugular vein distension, because as that blood backs up, because the left ventricle can't contract it out because it's broken, it backs up into the lungs. Well, it's a reverse pathway of blood. If blood can't get out of the lungs, that means that blood in the right side of the heart, in the right atrium and right ventricle, cannot get to the lungs. Well, it has to go somewhere. So this is where you'll start to see the potential for like JVD, where on their neck, their jugular vein gets really distended, because that's like the venous return back to the heart, and it's not getting in because it can't get out of the lungs to begin with, because the left ventricle is not doing its job. So oxygen's not getting around. That's the end of the story there. And as a result, they're also maybe cyanotic. So you look for some skin or, those discolorations. They will be confused. They're not getting enough oxygen. That disorientation, the restlessness. Again, what I like to say is the lack of perfusion leads to confusion. It can be lack of perfusion, just, they're not perfusing oxygen, or they're just not perfusing fluid, which is the same the blood, in the same in both of these cases, because the drop of cerebral perfusion pressure. Oliguria will also happen, and in cardiogenic shock, your fluid output, the monitoring of the eyes and nose is critical, because the lack of cardiac output results in the poor perfusion to the organs, including the kidneys. And again, when the kidneys are not perfused, they're not going to put out urine because there's nothing for them to filter out, to put out. As a result, that activates that RAS system, and the RAS system increases angiotensin II. And angiotensin II, ironically, will promote further vasoconstriction, right? Because the kidneys are telling the brain, I'm not being perfused. Here's the RAS system. Here's some angiotensin II. Let's constrict more because I need the blood. And again, this is not the problem, because they're already clamped down. And the problem is that they don't need the blood. They need the heart to actually do the job. So their urine output by effect is going to be dropped. Now, if you are in the United States, right, the last I checked, for urine output with patients in cardiogenic shock, you're going to see an output less than 20 milliliters per hour. So the NCLEX here, the National Licensure Exam in the US, still, at this point, the last I had checked, which was like maybe a month ago, so they still base, urine output for testing strategy on a minimum, in the adult population, a minimum of 30 milliliters an hour. So when you're reading, test questions, or when you're in clinical and you're thinking about it, if your patient is not putting out a minimum of 30 milliliters an hour, you have a problem. If they're putting out 30 milliliters an hour or more, technically, by their testing standard, it's totally fine. So what's interesting is, and what you'll see, and it may be similar, worldwide, is that usually those testing standards, they have a slower time catching up. Currently in the establishment where I work, right, we actually use a different formula for urine output, and it's based on, it's like 0.5 milliliters per kilogram per hour for output, because what we know is an individual who is 6'4" and weighs maybe 280 pounds versus another individual who's maybe 5'1" and 120-ish pounds, and roughly 120-ish pounds is like going to be, 55 kilos. So someone who's 5'1" and maybe weighs 55 kilos versus someone who is 6'4" and weighs, maybe 120 or 130 or 140 kilos, they have different blood volumes. And so we actually use a different formula because we know that there's this discrepancy. So you can't just say that, this person who's 6'4" and this person who's 5'1", the blanket 30 mils an hour is totally fine. That's not best evidence currently, but again, we're playing catch up. The other part of the presentation you're going to see is the labs are going to be abnormal. If you just reflect on everything we've talked about, the kidneys aren't being perfused. Well, what is the direct lab value that we use to evaluate kidney health? That's creatinine, for example. So it's going to be elevated. If you do arterial blood gases, they're going to show metabolic acidosis as a result of that hypoxia occurring because of the decreased cardiac output. Even the lactate will be elevated because the anaerobic processes sets in with the oxygen that's trapped in the lungs and it's unable to get out through that left ventricle. So you will see changes in your lab values just based on the lack of cardiac output. So that's essentially what your patient, they're going to look terrible. What are you going to do about it? And now here's your interventions. Here's the eye of the pie, okay? The whole goal with cardiogenic shock is reperfusion, right? It's similar. So like you have an acute myocardial infarction, you have to reperfuse the heart in order to get it to start working again or to reduce the severity, potentially long-term, of what will occur. Because increasing the cardiac output, right? We have to increase the cardiac output, and we can do it with medications to increase stroke volume. We also know that they're struggling on that breathing component because they've got the pulmonary congestion edema. And so we have to ventilate them appropriately. And that might mean that they need mechanical ventilation. We might have to intubate these people because we are also going to give them diuretics to help get rid of some of the fluid in the lungs so that they can appropriately oxygenate with the blood that is circulating. So increasing cardiac output is key for people in cardiogenic shock. And those with overt or like super obvious hypotension, they're going to be started on an inotrope or an inopressor. Because depending on the severity and cause, you would anticipate treatment for that they are probably, again, the severity and cause. Cause is key. Is it a coronary issue or is it a non-coronary issue? Because if it's a coronary issue, they need to go to the cath lab and have maybe some sort of percutaneous intervention or a stent if it's from an MI, right? They might need that mechanical circulatory support if it's bad enough, like an Impella or an intra-aortic balloon, if it's like the result of an acute on chronic heart failure exacerbation. So you need to figure out, first you have to figure out that you've identified cardiogenic shock, and then what is the cause and address that, because that is how we stop the damage and improve the outcome. You will monitor for that adequate perfusion, the tissue perfusion. You'll look at the blood pressure, the skin color, capillary refill, urine output, that's huge, mental status, lung sounds, all of it. And the other interventions that we do, right, we can do medical management. So in the meantime, oxygen. We're still going to give these people oxygen because we want to maximize what little they have that's being perfused. We can also, if you think about it, if it's a coronary issue, again, this is why it matters that you identify, is it a coronary or non-coronary cause that is the result of the cardiogenic shock, right? Because we can do pain control. And we do pain control because, for example, tissue that is not oxygenated starts to die through that ischemic process. And the ischemia itself is very painful. Think about a heart attack. It's very painful. It's uncomfortable for those people because the hypoxic, event with those skin cells is not very pleasant feeling. So we want to give them oxygen, give them pain control. Fluid. You don't want to just jump on fluid right away. They don't have a fluid problem. They have a pump problem. And dumping fluid in these individuals can exacerbate the issue by putting more stress on the heart and making it not work less than it is already doing its job. So from that nursing perspective, when we think about interventions, we want to monitor those vital signs, monitor the urinary output, give the medications, and that might be a diuretic if their lungs are super junky. Consider those vasopressors and positive inotropes to help maintain organ perfusion, and then consider what it is ultimately that they're going to need. Do they need to go to the cath lab for a stent? Or do they need to go to the cath lab because they have the acute on chronic heart failure and now they need some sort of mechanical support like an Impella device? And start the preparation for that, because from a pharmacology standpoint, a pharmacological management, the vasopressors with positive inotropic features, the most common ones that I see in play for people in cardiogenic shock, or if people in shock where we need to kind of help support and increase the cardiac output, are going to be epinephrine, norepinephrine, dopamine, and dobutamine. You also have other medications like milrinone and digoxin, and they work to increase the cardiac contractility. But the reasons why they end up with vasopressors is because we need to constrict the vessels. By constricting the vessels, right, it increases preload and increases blood pressure, thereby increasing cardiac output, assumingly. I'm going to tell you about a different play here. The norepinephrine increases tissue perfusion and blood pressure. Now, your positive inotropes, again, right, those inotropes increase the strength and contraction. So you get more bang for your buck. So when that ventricle squeezes, it's stronger. Because, again, think it's a sprained heart, or, in that sense, the sprained ankle, the running, that thing, right? Your heart can no longer run its normal marathon. So we need to actually help it to increase the contraction. So with those positive inotropes, increasing that strength of the contraction, you get more blood volume out, but with less work from the heart. The dobutamine, for example, if you're ever giving that increases the contraction and the stroke volume. However, dobutamine's interesting because it also has this vasodilation process. And if your patient is hypotensive, right, we don't want to cause necessarily vasodilation because it's going to make it worse. The dopamine increases the contraction, blood pressure, and stroke volume, but dobutamine causes the vasodilation. It's longer, right? Dopamine can exacerbate tachycardia. So dobutamine and dopamine, they do come into play at some point, but more often than not, most places, when their patients are hypotensive, they actually start with an inopressor, some sort of combination of a vasopressor and an inotrope. And I am not a provider at all, okay? And so I'm basing this off of what I've seen and what I've read about, but it seems that most places or institutions are actually going to start with norepinephrine first, and then they start with the norepi, and then they add on epinephrine or dobutamine to help increase the coronary artery pressure. Because when we start, and here's where this is a little bit of a complicated concept, but if you can master this, you will really understand cardiogenic shock and why we do the treatments that we do. So when we start only with norepinephrine, one of the things that we focus on as nurses is that MAP, or the mean arterial pressure. And again, that number is calculated by multiplying the diastolic blood pressure. So you take your diastolic blood pressure, multiply it by 2. And then you take that number and you add it to your systolic and you divide the whole thing by 3. And literally the equation looks like MAP equals 2 times diastolic plus systolic divided by 3. The problem with this is that when we crank up the norepi dosing, it's probably not the best practice. And hear me out on this, because from an ER perspective, right, and especially as a nurse, like, this is not my wheelhouse. Like, my whole shtick in the emergency room is like, stabilize them, transfer them. So when we crank up the norepinephrine, we are actually cranking up the systemic vascular resistance. But the systemic vascular resistance, by doing this, we are actually at the expense of cardiac output because we're only looking at the MAP. So when I'm giving someone norepi because they're in shock, I look at the MAP because I want to maintain, and again, it's different based on your patients, but typically you want to maintain a MAP of greater than 65. And we do this, right? We're increasing that systemic vascular resistance because as we do it, as we give them the norepi, it decreases the vessel diameter in the body through clamping them down. And as the vessels, again, think in these patients, what do their hands and feet feel like? They're already cold. But when we clamp those vessels down, we funnel blood back to essential organs, thereby increasing blood pressure because we're essentially delaying arterial blood flow forward. So the arteries have to meet with the vessels or the veins at some junction, usually in the cells or, at your distal extremities. So by principle, this sounds great for people with shock because by decreasing the blood's ability to flow freely through the arteries, we're also, we want to increase the blood pressure. And so we do that by clamping down the arteries. We clamp the arteries down with, for example, norepi, increasing systemic vascular resistance, which means more of the blood stays in the localized and important zone, your heart, your lungs, your brain. The problem with this in cardiogenic shock is that by decreasing the lumen size of the arteries to increase systemic vascular resistance, we are then also decreasing the blood's ability to get to the end point to freely flow, and then we are decreasing venous flow back to the heart. Okay, think about that for just a minute. If you sit there and you envision it, okay, when we give norepi, okay, which is a vasopressor, right, because we want to constrict the vessels to increase the blood pressure, and we're watching the map because the map is driven off the blood pressure. We do that, but by virtue of doing that, the blood then can't get from the arterial system to the venous system, so we have less blood flow going back through the venous system. In many ways, here's the problem with this, with just fixing the map to increase that systemic vascular resistance. We know that the SVR, systemic vascular resistance, okay, is a direct reflection of the changes in those blood vessels when they tighten and constrict. Okay, that when they tighten and constrict, we increase vascular resistance, and that leads to the decrease in venous return, but also it leads to a decrease in ventricular compliance and leads to a reduced stroke volume, which ultimately causes a drop in cardiac output. But the whole thing with cardiogenic shock is we have to increase cardiac output. So if you just sit there and you solely fixate on like giving norepi and decreasing, clamping those vessels really hard, we are also decreasing cardiac output. So one way to think about this as nurses, because we're looking at the map and we correlate the map to the mean arterial perfusion, we correlate it to organ perfusion. Yes, of course, but consider that if your patient that you're taking care of is in cardiogenic shock, okay, as we try to increase their systemic vascular resistance to increase the map, we do that. And we will see that initially. By reducing that, we reduce the arterial lumen, the arterial diameter, okay, we clamp those vessels down. We are also reducing the blood that can enter the venous system and return back to the heart. And the arterial flow is now backed up. So increasing systemic vascular resistance leads to a decrease of cardiac output ultimately. And generally speaking, okay, if you're going to be running norepinephrine, for example, it's not a bad idea, and this is, you read the literature to find this out. It's not a bad idea to think in your head, okay, let's keep it at a lower level, like below 0.1, and then think about adding an inotrope on to increase cardiac output, because the inotrope is going to increase the squeeze of the heart. And this is the key to maintain that perfusion and pressure balance that's needed with cardiac output. So yes, we clamp vessels down so that there's more blood available, and then we actually have to increase the heart's ability to get the blood out. So that is why don't just fixate on the map is my whole point there, and don't just crank your norepi up all the way. You have to have the vasopressors and the inotropes that work to maintain the balance of pressure and perfusion. So you may also see a drug called milrinone, which is used for cardiac support in people with heart failure, pulmonary hypertension, etc. And it's used because it improves cardiac contractility, that inotrope. Yay! That's what we're looking for in cardiogenic shock. And it has an element of cardiac relaxation, which that fancy word is called lusitropy, and it causes vasodilation. And you're like, oh, that sounds great. So if we can increase contractility by squeezing that heart more, we can relax the heart a little bit that's already on the struggle bus, and we cause some vasodilation while we are giving a vasopressor, then we have this nice balance. But the problem with milrinone, especially in an acute care setting, is that you can't really titrate it very easily as you can with, say, dobutamine, right? And reflect back, dobutamine has those vasodilation components, which we worry about because it can make hypotension worse. But being able to titrate dobutamine or epinephrine is much easier than milrinone, because milrinone has a 2.5-hour half-life, and it's not something that's easily titratable. It's also renally cleared, and if you're already hypotensive and you've got that increased systemic vascular resistance going on, the kidneys are restricted on their blood flow, so it's not really going to be cleared efficiently or effectively. So what you're most likely to see in ICUs are patients that are started on dobutamine if you need that inotrope, and then they will switch them to milrinone once that renal system has recovered. And how do you know it's recovered? Your answer should always be good urine output, right? If the renals are being perfused, you will have good urine output. So all of this to say, is that your nursing intervention in cardiogenic shock, right, is really you need to understand the end game here and how it's played, because we know that perfusion affects every single thing. So we need to, again, big picture, interventions, not only give the medications, but understand why you're giving those medications, monitor the vital signs and trend them, monitor and trend their cardiac status, considering the heart sounds, look for that jugular vein distension, maybe eventually or down the road, potentially, your heart failure patients, peripheral edema, and what is their rhythm doing? Do they have any dysrhythmias that you anticipate that you need to watch for? The respiratory effect, look at their effort. Listen to the lung sounds. Are they wet sounding? When you're monitoring them, look for respiratory distress or signs of respiratory distress, that decrease in oxygen status, because if we have that decrease in oxygen status neurologically, what is their level of consciousness? Are they restless? Are they confused? Are they altered? Because we know that cerebral hypoperfusion is going to cause these symptoms. And urine output, it's a big one. We know that a lot of the medications we're giving are renally cleared. But in shock, the organs that are going to suffer first with the clamp down, the body's natural ability of clamping down, and then we're going to give a vasopressor, which is going to do it even more, is going to be your GI tract and your renal system. So you need to monitor for the decreased output or oliguria. Now, that's a wide array of interventions. When we think about evaluation, okay, the E of the pie, when we evaluate, we're looking to actually see that if the patient in cardiogenic shock, with everything we've done or talked about from above, do they have adequate cardiac output? And the easiest way is whether or not, right, the easiest, most simple way is for cardiac output, just check their distal pulse, their peripheral pulse. If they have strong peripheral pulses, because the pulse you're feeling on the radial artery or on the carotid, well, carotid's really centrally located, but if you go to the radial artery, if you can feel a strong peripheral pulse on their foot, then you know that ventricular squeeze is sending blood to that destination and their cardiac output is good. The other things to consider with whether or not the cardiac output is being maintained, you can of course look at what is the heart rate doing? Is it between 60 and 100 beats per minute with some sort of regular or unconcerning rhythm that you're watching? We also know that, they come in cold and wet because of the pulmonary congestion and the clamp down, the vascular clamp down that they've done. So when you evaluate whether or not what we are doing is actually working, you have to consider that gas exchange effect. So the ABGs should improve. Their effort of breathing should become easier or more normal. And as a result of that, their mentation or their level of confusion or restlessness should improve, and they should be relaxed with breathing. So all of this to say that when you think about the nursing responsibilities and interventions for cardiogenic shock, there's a lot. Okay, we really need to consider and manage cardiac output, which means keeping eyes on what does your patient look like and the interventions that you're doing. Do you see the changes in the vital signs and in their lab work and just in how they look? Are they worsening or are they improving? Because we need to maintain the optimal oxygenation and gas exchange, because that is going to directly correlate with tissue perfusion and will decrease their neurologic changes if they had them. And oftentimes, if you've ever been short of breath or if you've ever been swimming in a pool and you've been at the very bottom of a pool and you underestimate your ability to get to the top and you have a fleeting moment of hypoxia before you hit that surface, you get panicked inside the water. Okay, that is similar, but these individuals are just not in water, but there's, theoretically fluid in their lungs. And so managing their fluids and electrolytes down to their intake and output is essential. And we're not going to dump fluid in these people because it's not a fluid problem per se, right? It is a pump problem. So we have to be really careful with these patients who have cardiogenic shock with fluids because the heart is not working, and we want to anticipate and consider this. So that is kind of everything that I have on the nitty-gritty aspects specifically of cardiogenic shock, and interestingly, more about the pharmacological features of that and how we address it. Hopefully it was informative for you. I'm not an expert by any means. I will be coming out with an Impala device and intra-aortic balloon device podcast. This was too long to incorporate in there, but there is that feature for the cardiac support in patients who have cardiogenic shock or other complications. So stay tuned for that one. And I think that is it. I hope you all have a great day. Go forth and keep on learning. Thanks for listening to this episode. If you've enjoyed what you've heard or enjoyed listening to these episodes, please make sure to rate and leave a review in the platform you're listening to it in. If you'd like to support the show, check out the podcast description for a link to the Nitty Gritty Nurse shop where you can purchase items. This podcast is meant for education and entertainment purposes only and is not meant to serve as medical advice. Please consult a qualified healthcare professional for advice. I strive to provide accuracy, but errors may occur and medications, protocols, and best available evidence may change over time.